In 2013, the architects of the world's standard psychiatric diagnostic manual made a startling admission. Thomas Insel and Stephen Hyman, both former directors of the National Institute of Mental Health, described the DSM diagnostic categories as an unintended epistemic prison that lacked actual biological validity. Despite 50 years of biological psychiatry and billions of dollars injected into genomic research, scientists have failed to identify a single biological marker that reliably distinguishes one DSM category from another. This zero-yield result is not a matter of insufficient funding, poor technological resolution, or a lack of genomic data. You cannot find the biological marker for a category that does not exist in biology. The diagnostic criteria we use to define mental illness do not carve nature at its joints. They are contingent assemblages of symptoms, not natural biological kinds. When the leaders who built a scientific system describe their own framework as a prison, the system is already dismantling itself. The search for a replacement framework is actively underway. The core epistemological flaw of current psychiatric practice is dimensional. Diagnostic checklists operate by mapping human experience onto flat, two-dimensional linear severity spectra. Compare that approach to the Moser Laboratory's 2022 findings in neuroscience. Their research demonstrated that even simple neural representations of physical space require high-dimensional toroidal manifold topology. This visualization shows what happens if you try to squash a multi-dimensional toroidal shape flat onto an XY scatter plot. The geometry breaks. The flat grid cannot capture the original structure. Because the brain requires higher dimensional topology to represent physical space, plotting the complex field of consciousness onto a two-dimensional spectrum guarantees clinical failure. Driven by the weight of its own anomalous evidence, mainstream psychiatry is currently undergoing a silent transition. It is moving toward a field-based understanding of consciousness. To successfully escape the confines of diagnostic categories, the field must align its clinical measurement tools with the actual dimensional geometry of the mind. The assumption underlying modern psychopharmacology is that targeted chemical interventions reduce the overall burden of disease. But population-level epidemiological data tells a contradictory story. This line graph illustrates Robert Whitaker's findings. Over 50 years, as psychotropic prescribing scaled upward, psychiatric disability tripled. Standard explanations suggest better diagnostic identification, but better identification cannot mathematically account for an exponential parallel correlation between increased medical treatment and systemic disability. To isolate what happens at the individual level over time, Martin Harrow initiated the Chicago follow-up study, tracking patients diagnosed with schizophrenia over 20 years. These diverging lines show Harrow's results. Beyond 2 years, patients discontinuing antipsychotic medication consistently demonstrated higher recovery rates than those remaining medicated. Lex Wondering's trial replicated this, showing a 40.4% recovery rate for dose reduction, compared to 17.6% for maintenance. A clinical framework cannot sustain itself when strict adherence to its primary treatment protocol correlates with worse longitudinal outcomes. The categorical disease model lacks the theoretical architecture to explain its own data. While chronic disability metrics rise under standard protocols, several distinct interventions are producing massive, anomalous success rates that the mainstream acknowledges but struggles to explain. In Western Lapland, an approach known as open dialogue achieved an 83% return-to-work rate for patients experiencing first-episode psychosis. This method produced an 80% reduction in the incidence of schizophrenia over the study period, doing so with minimal use of neuroleptic medication. Simultaneously, major clinical trials at premier institutions like Johns Hopkins are using psychedelics to treat severe depression and existential distress. The data from these trials revealed that a patient's therapeutic outcome correlates almost entirely with the intensity of their subjective mystical experience, and not with the pharmacological dosage of the drug. This creates a stark, undeniable clinical paradox. A patient experiencing intense boundary dissolution in a highly supported clinical trial achieves lasting therapeutic recovery. A patient experiencing that exact same phenomenological content in a standard hospital ward typically spirals into chronic fragmentation. The failures of lifelong maintenance medication and the high success rates of open dialogue and psychedelic therapies point to the same conclusion. The determining factor of medical recovery is the relational field surrounding the patient, not their diagnostic category. These seemingly disparate outcomes resolve clearly through this single field equation. Experienced consciousness equals neurological capacity minus constraint load. This neurological capacity is dictated by three-dimensional field parameters: relational ground, field coherence, and field volatility. Open dialogue succeeds because it maximizes relational ground and builds inherent capacity before a clinician ever attempts to artificially suppress the patient's constraints. Psychedelic therapy operates on the exact same math. It temporarily relaxes constraint loads while holding extremely high volatility inside a tightly secured relational ground. This identical equation explains the Harrow and Whitaker data. Long-term neuroleptics aggressively suppress constraints, but fail entirely to build internal neurological capacity. When you suddenly remove that chemical suppression from a system with no capacity, the entire system crashes. This severe state of iatrogenic fragility is routinely misdiagnosed as an underlying disease relapse. What mainstream psychiatry historically categorizes as chronic, lifelong mental illness is frequently an interrupted biological transformation process. It is trapped in a frozen state by a medical framework that lacks the mathematical variables required to let it complete. Operating within a field-based framework does not require abandoning the clinic, discarding therapeutic alliances, or throwing away the prescription pad. It simply requires resequencing the logic of the clinical encounter. The conventional psychiatric workflow is rigid. Identify a categorical diagnosis, locate the corresponding treatment protocol, and write a prescription to suppress the symptoms. This flowchart illustrates the contrast. The new approach asks a prior question: which dimensional field parameter is destabilized? Then calculate whether to build internal capacity or suppress constraint load. Prescribing still occurs, but physically later, only after mapping these variables. By simply shifting the primary question asked at the bedside, practitioners stop treating arbitrary diagnostic categories and begin directly addressing the underlying geometry of human consciousness. Pharmacological suppression remains a valid necessity in acute crises. Constraint modulation is a vital emergency tool to prevent immediate fragmentation. However, employing that tool carries an absolute requirement: a precise exit strategy, utilizing logarithmic, hyperbolic tapering protocols, must be established at the exact moment a medication is initiated. Without an exit strategy, clinicians routinely conflate chemical withdrawal phenomena with genuine clinical relapse. This diagnostic error ensures patients remain trapped in cycles of lifelong dependency. Long-term biological suppression without concurrent capacity building is not medical recovery. It is merely suspended animation. The internal evidence generated by the psychiatric establishment has created unstoppable momentum. The systemic structure is actively fracturing under the weight of its own data. The destination has already been mapped, and the field evidence is undeniable. The only remaining choice for mainstream psychiatry is how quickly it will recognize the direction it is already heading.